bringing together voices in child and youth healthcare. This is CAPHC Presents.
CAPHC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, the Holland Bloorview Children's Rehabilitation Hospital Foundation, and the Children's Hospital Foundation of Saskatchewan. We would also like to thank the following Keystone and program partners for their ongoing contributions that support all of CAPHC's programs and activities. If you have any questions or comments for our panelists, please type them into the question box at any time during the presentation. You can also share your thoughts and questions on Twitter by tagging @CAPHCtweets and using the hashtag CAPHCpresents. All of our webinars are recorded and can be found on the CAPHC Knowledge Exchange Network. Use the CAN to share these recordings with your colleagues or register an account and post comments, links, or other resources that you think will be of interest. And be sure to sign up for the CAPHC Presents weekly email newsletter to stay up to date with upcoming webinars and our recorded webinar archive. All right, hello everyone, and welcome to today's episode of CAPHC Presents. My name is Doug Maynard, and I'm the Associate Director at CAPHC, the Canadian Association of Pediatric Health Centres. And we've got a great presentation today, but before we get to that, I'd just like to mention the 2016 CAPHC Annual Conference being held in Halifax, Nova Scotia this year from October 23rd to 25th. There's lots of time to register still for the conference, so hopefully you'll take an opportunity to check out the website and hopefully register, and hopefully we'll see lots of our CAPHC Presents audience maybe in person for once instead of virtually every week. We'll get a chance to meet some people in person at the conference. So please do check out the website, and if you can spare the time, please join us in Halifax. All right, today's webinar is titled Pediatric Sepsis: The Importance of Data as a Foundation for Improvement. It's a great pleasure to welcome everyone to today's webinar on the day following World Sepsis Day. World Sepsis Day is an initiative of the Global Sepsis Alliance, which is an organization that supports the efforts of over 1 million caregivers in more than 70 countries as they seek to better understand and combat what many experts believe to be the leading cause of death worldwide. Today's presentation has come at the suggestion of some of our colleagues who participate in CAPHC's Sepsis Community of Practice. And this is a great opportunity for us to play a role in raising awareness around some important issues related to sepsis in support of World Sepsis Day. And if following the presentation you're interested in more information about what we're doing here at CAPHC related to sepsis, please go to the CAPHC Knowledge Exchange Network. You can click into the Communities of Practice section and see lots of the work that the Sepsis Community of Practice has been doing, including their sepsis screening tool that they've been working on. All right, so without any further ado, let's introduce today's panel. First off, we're going to be hearing from Dr. Melissa Parker. Dr. Parker is an Associate Professor of Pediatrics and Clinical Epidemiology and Biostatistics at McMaster University. She's also certified in Pediatric Critical Care and Pediatric Emergency Medicine and is a staff physician at McMaster Children's Hospital. And Dr. Parker also serves as an invited ambassador for the World Sepsis Day Initiative. And joining Dr. Parker is Jane Stewart-Minaret. Jane's focus is in pediatric emergency nursing, and she works in the Division of Pediatric Emergency Medicine at the Hospital for Sick Children in Toronto. She's always looking for ways to improve and enhance the care for emergency patients, and Jane has completed a personal learning fellowship with the Registered Nursing Association of Ontario focused on emergency care of these pediatric septic patient. So some real expertise on the panel today, and as a reminder, please, as we mentioned earlier in the intro, do type in your questions as you think of them, as we do have some great expertise on the panel who are ready to take your questions and engage your comments. So without any further ado, it's my pleasure to hand the virtual podium first off over to Dr. Melissa Parker. Over to you, Dr. Parker.
So you should be able to see my title slide here with the title of today's talk. Thank you again for the invitation. First of all, just by the way of disclosures, I'd like to just inform everyone that I do hold grant funding, peer-reviewed grant funding, to do research and quality improvement work in pediatric sepsis. So I suppose my conflict of interest is I'm interested in pediatric sepsis and research and knowledge translation. I don't have any links to industry relevant to this talk. In terms of objectives for today, I thought we could frame them under these headings. We'll talk a little bit about the importance of sepsis data in relation to the World Sepsis Day Declaration, recognizing yesterday was World Sepsis Day. We'll review what we know about pediatric sepsis in Canada. We'll talk about some challenges relevant to getting good data, talk about potential metrics of interest in relation to pediatric sepsis care, and then highlight the importance of good data to supporting continuous quality improvement. And Jane is going to provide us with a nice example from sick kids. So the World Sepsis Day Declaration really is a group of organizations that came together to try and improve the care and outcomes for sepsis, and also to increase knowledge of sepsis, because the vast majority of the lay public don't necessarily understand what sepsis is. But as you can see here, sepsis is estimated to impact 20 to 30 million patients worldwide annually, with over 6 million cases of neonatal and early childhood sepsis. So it's a big problem. The World Sepsis Declaration specifically, there's 5 global goals and 5 key targets that they have outlined to be reached by 2020, and I'll let folks on their own time look that up on the World Sepsis Day website. But what I wanted to highlight here was key target number 5 is based on data. And so really they're recognizing here that the measurement of the global burden of sepsis and the impact of sepsis control and management interventions needs to improve, and that right now we're really lacking good quality registries to try and track this data globally, and that data is really an important piece of the puzzle in terms of improving our understanding both of sepsis epidemiology and improving sepsis care. So anytime that you talk about sepsis and data, I think the analogy of trying to find the needle in the haystack is one that's very relevant, because first of all, if you're looking for a needle, you have to know what the needle looks like, and second of all, you have to define what haystack you're going to look in. And that is particularly problematic with sepsis for a variety of reasons, which we'll discuss. So when we think about what we're actually trying to achieve in terms of our end goals for children with sepsis, if you're wearing, for the clinicians in the audience, if you're wearing your clinical hat, then actually that's pretty obvious. We want to identify kids with sepsis as soon as possible. We want to provide the treatments that we know work in a timely fashion, and of course we want to improve the clinical outcomes for patients. So that all sounds very neat and tidy and very simple. But from a research perspective, there are actually a number of issues, and it's quite possible that my presentation today is going to raise more questions than answers, and so hopefully we're going to have lots of time for discussion. But first off, can we actually agree on what a sepsis case is? Because if we're going to track cases and look at data, then we need to be able to have a robust case definition. Secondly, can we actually agree on what haystack we're going to look in for our sepsis cases? Are we only going to look in the emergency department in terms of children presenting through that route? Are we going to look on the wards? Because we obviously know that cases of sepsis develop in inpatients as well as within the PICU setting. Are we only going to look within pediatric tertiary care centers? We know that children with sepsis obviously present to community hospitals as well. And are we interested in all children seeking care, or a subset of children who are seeking care? If we agree on those things, can we actually agree on what quality metrics are actually important to assess and track? And for specific quality interventions for those people who are trying to actually improve sepsis recognition and the timeliness of treatment, do we actually know that those interventions work, or can we actually track data such that we can actually prove whether the interventions that people are coming up with and implementing are actually changing outcomes for patients? And lastly, of course, for the administrators in the audience, we can come up with all sorts of different quality interventions, but if they're costly and they don't improve care, then are they worth continuing? So how much of an issue is pediatric sepsis in Canada? So I want to give you just a little bit of a taste of the lay of the land here. And this is certainly a point of discussion. So first off, there was a key paper that was published back in 2001 that's actually published by a group in the U.S. And as you can see here, this is actually United States data, but the reason that I'm actually mentioning this paper is because these statistics are widely cited, is that the national estimates from U.S. data is that there are 3 cases of severe sepsis or septic shock per 1,000 population. And so if we take that case rate and then we extrapolate that onto Statistics Canada population data, and we think about how many cases of severe sepsis and septic shock we might have in Canada using that case rate, then that really would yield more than 100,000 people developing severe sepsis in Canada each year, including 23,000 children. So that would suggest that if we extrapolate from U.S. data, that we actually have a very big problem on our hands. Now, of course, that's U.S. data. So what sort of data do we have in Canada? And I do need to confess that I actually haven't personally worked with CIHR data, so this isn't an area of expertise, but I'm including it here because it is important in terms of the data that is available in Canada. So what I've put up here is information that CIHR is now tracking as part of its hospital harm initiative, and so they've created a metric of in-hospital sepsis. And I've included the description here just for interest sake and for discussion. And they're basically generating rates of in-hospital sepsis for inpatient sepsis for patients who've been admitted for at least 2 days and who are at least a year of age. And they've been tracking that data for several years now, and I don't know if there are any CIHR people on the phone, but I know that they've been working hard to refine that indicator, and people can actually go onto the CIHR website and actually look up their own site's in-hospital sepsis rate. Now, interestingly, here in Hamilton, when I've gone onto the site, I'm able to pull up the rate for Hamilton Health Sciences, but I wasn't able to pull up the rates specific to the Children's Hospital. So the CIHR data, their inclusions are that the sex of the patient needs to be known, they need to have been in hospital at least 2 days, they need to be a Canadian resident, and then there's a number of exclusions listed here. And perhaps most relevant to this talk, age at admission less than 1 year. And the CIHR data is based on essentially discharge diagnoses and application of ICD-10 codes to patients. So the caveats and limitations to the CIHR data that are listed on their website is that obviously in-hospital sepsis can be either due to community or hospital-acquired infections. Therefore, the indicator doesn't necessarily capture hospital-acquired infections only. Also, despite national coding standards, there may be variations in charting and coding practices across the country that could impact the results. And so while the CIHR data is providing us some data on in-hospital sepsis, it's certainly not the whole picture. So Dr. Thompson from Alberta Children's Hospital published this article with colleagues back in 2014. And this is perhaps our best snapshot of what's going on with children with sepsis in Canada. And this was basically an analysis of data, a 5-year cohort using CIHR data from 2004 to 2009. So as you can see on this table here, they've listed on the left-hand column, you can see the age of the patients here in terms of the age brackets, and then they've divided the cases in terms of all comers with sepsis, and then those with severe sepsis, which should include children with septic shock. So what I'll just draw your attention to is on the bottom here, if you look at the total number of cases, a few moments ago I told you that extrapolating from U.S. data, we would think that we would have probably around 23,000 pediatric cases of severe sepsis annually. But as you can see here, in their cohort study, they identified a little over 20,000 cases over the 5-year period, as well as a little over 4,000 cases of severe sepsis, which would include septic shock. Now, the authors of this paper do list a number of limitations, including the fact that their data do not include data from Quebec, and also the same limitations related to use of ICD-10 in discharge diagnosis coding limitations would apply. And so we've got some information from this paper, but again, it's certainly not the whole picture of how children are impacted by sepsis in Canada. Here's a nice graph from the Thompson paper, which is actually just showing us the distribution of sepsis across the age brackets, and we know that younger patients constitute the preponderance of sepsis cases, and that's nicely shown here. So I've just really given you a few snippets of data, but together, hopefully, that illustrates that we do have gaps in our knowledge regarding sepsis epidemiology in Canada. We have some information, but it would certainly be great to have more. The other thing that is, I think, important to show, particularly for the administrators in the audience, is sepsis is extremely costly. And so not only is it a prevalent problem, but it's an expensive problem, and so that it's something that's worthy of our attention. Again, the cost being highest in the youngest age groups, and this is U.S. data here. But this paper published in 2001 put the national annual cost in the U.S. at over $16 billion, and that's in 1995 U.S. dollars. So I alluded to this earlier, but do we really know who we're talking about when we refer to sepsis cases? Because if we want to look at quality indicators and metrics, we need to agree on who we're talking about. So these are two different articles that some people will be familiar with. The first is the International Pediatric Consensus Conference definitions for sepsis and organ dysfunction in pediatrics, and that's the paper that really has given us the research definitions for severe sepsis and septic shock. On the bottom, however, I'm showing you here the Sepsis 3 publication, which actually just came out earlier this year, and these are the new proposed consensus definitions for sepsis and septic shock. Now, these definitions are applicable to adults, and there has been actually quite a bit of discussion and controversy around these new definitions. Looking at some other papers from authors who've examined issues around sepsis definitions, Dr. Weiss is based at the Children's Hospital of Philadelphia, and he's done a very nice single-center study where they looked at patients admitted to their pediatric intensive care unit over a 13-month period, and they wanted to identify within that cohort which patients met the research, clinical, and administrative definitions for severe sepsis, respectively. And as you can see on the left-hand side here with this Venn diagram, I think that this nicely illustrates that these research, clinical, and administrative definitions, while they overlap, they certainly are discrepant, and that is problematic. From another group, Dr. Ruth et al., they looked at the Pediatric Healthcare Information Systems database, which is from the Children's Hospital Association, and they looked at a very large cohort of almost 50,000 patients under 19 years of age. And again, they limited their analysis to patients who were admitted to pediatric intensive care units. So again, that doesn't comprise all patients with sepsis who we're concerned about, but this is what these authors looked at. And you can see again on the left here that they have three different definitions, and those three different definitions for cases, while they overlap, they're certainly not the same. So you've got the largest subset is the modified Angus criteria, which are infection plus organ dysfunction, followed by severe sepsis, which is the ICD-10 code or ICD-9 code for severe sepsis as shown there, and then cases of septic shock, which really should completely overlap with the severe sepsis cases, but they don't, and they're identified through a separate ICD-9 code. So if we were using any one of these methodologies as our gold standard for looking at cases, or if three different people looked at them in different ways, then you're going to come up with three different answers. So moving on to what metrics are potentially of interest for cases of sepsis. I think this gets a little bit easier because we have the surviving sepsis guidelines in terms of what is currently recognized as best practice and that we aspire to. So if we think about what metrics might be important following recognition of sepsis, that really would focus on the upper hand of, or upper portion of this algorithm: early recognition, early resuscitative measures, and then, of course, the lower part of the algorithm is care that is more directed towards ICU care, goal-directed endpoints. So looking at this a different way in terms of what those early metrics might be, we can think of sepsis presentation because, of course, patients develop symptoms. That's not necessarily the same as when patients with sepsis are actually recognized. They then have to get vascular access if we're going to deliver some of the therapies that we consider important. And probably the big ones on that list would be initiation of a fluid bolus, antibiotic therapy, and initiation of vasoactive support for patients who have septic shock. And of course, at the end of all of that, our patients experience a clinical outcome. But what I wanted to overlay here, well, first of all, at the bottom, you'll see that I've noted that right now this is shown in a linear fashion, and of course some of these interventions may be happening simultaneously. Equally, the order of these interventions could be different. The antibiotics might go in before fluids, and that's not incorrect. This is just showing what a typical progression down the algorithm would be. And I wanted to overlay on top of this the fact that when we think about what metrics are of interest, we also have to consider that on a background of what the underlying evidence for the current guidelines are and why sometimes they may be followed and in other cases they may not be followed. So what are the important practical considerations when we're actually considering what therapeutic interventions might be candidates for metrics that we might want to follow? Well, we need to be cognizant of the level of evidence supporting guideline recommendations. We also need to appreciate that evidence is constantly changing, and so whatever metric you're choosing to follow, you would hope that it would be robust over a period of time. And then lastly, I think we need to pick sensible metrics that have got good faith validity among stakeholders. And if I just for a second go back to this algorithm, you can see the timeline on the left shows really that boluses should be pushed 20 cc per kilo up to and over 60 cc's per kilo, and really it looks like that should be happening within 15 minutes. But that may be appropriate in some cases, but in other cases it may not be appropriate. And that's actually the example that I wanted to give you specifically with respect to fluid therapy, because that's an area that we are currently doing research in, is that some of the treatments in the septic shock guideline are not based necessarily on strong evidence, and they may be controversial, and fluid's a good example of that. So you can see here systematic reviews that have shown that fluid bolus therapy may be harmful, and that fluids and sepsis, we're talking about totem and taboo in terms of maybe it's a good thing, but there can be too much of a good thing. So we've recently completed a pilot study for what we've called the SQUEEZE trial, which is looking at a usual care strategy of liberal fluid versus a fluid restrictive resuscitation strategy in children with septic shock. And you can see the supporting funding agencies here, and that's also supported by the Canadian Critical Care Trials Group and Pediatric Emergency Research Canada. And we've recently actually, just in July, received notice that we've been funded by CIHR for a large multi-center Canadian trial looking at this specific question. So stay tuned and be aware of the fact that when we're thinking about metrics to track, we need to recognize that evidence is a moving target. So what about actually presenting data? So if we can agree on case definitions and agree on metrics that would be of interest for us to collect and track, how might we actually look at that data, and how might we show it in a way that's useful not just to researchers but also to clinicians and to administrators, to make it meaningful and also responsive such that we actually can track that data in a timely fashion to identify both when things are working well and when there's a problem that needs to be addressed. So statistical process control charts are one way of tracking data, and the use of this presentation method is relatively young in healthcare. The hallmark of SPC analysis is the control chart, which I'm going to show you in a minute. And these control charts track data continuously over time and have what are called upper and lower control limits, which really show you the bounds of 3 standard deviations within which almost all of the values should be expected to fall when a process is in control or stable. And I'm going to show you how some groups have actually used SPC charts to look at sepsis metrics in their hospitals. As I said a moment ago, the control chart, the data points actually fall within those upper and lower control limits when a process is stable. And when data points actually start to move outside those bounds, that's what's called special cause variation, and means that there has been a change. So that change could be a positive change, meaning there's been a quality intervention, and so the metrics are improving, or alternatively, it could represent a deterioration in metrics. And SPC analytics have become popular in healthcare because the control charts are intuitive and easily comprehended by non-researchers. So here's an SPC control chart where this group actually chose to look at, you'll see on the y-axis, they wanted to see how many minutes it took them to get a first fluid bolus into a patient. And this is data from the Children's Hospital in Texas. And what they're showing here is their data pre and post institution of a shock protocol. So you can see on the left-hand side of the chart, it's taking them many minutes to get the first fluid bolus into their patients. But over time, and certainly after the dashed line is noted, you can see that the time to first fluid bolus dropped dramatically. Now this is another group in Utah that again has used an SPC chart to look at their efficiency of fluid delivery in patients with sepsis. But as you'll note on the left-hand side, they haven't charted it as time to first fluid bolus, but rather the percentage of children who receive 20 mils per kilo within the first hour. So they're looking at fluid therapy, but they're looking at it in a different way. So this is a good example of how people can be interested in the same thing, but the metrics can be different. And as you can see over time, pre and post institution of a shock guideline in their center, they saw an improvement in the percentage of patients who actually received the first bolus within the first hour. And these are both studies conducted in emergency departments. Looking at antibiotic administration, again, this is from the Texas group. You can see that they looked at time to antibiotics. Before institution of their shock protocol, it was taking them many hours in a number of cases to get antibiotics into the kid, whereas after institution of their shock protocol, the time to antibiotics dropped dramatically, suggesting that their protocol was effective. And here, the group in Utah looked at, again, the percentage of patients who received antibiotics within 3 hours after institution of a shock guideline at their site, and they saw an increased percentage of patients receiving antibiotics within what they considered a timely fashion after institution of their protocol. Now, it's also worth noting that the surviving sepsis guidelines actually state that antibiotics should be given within an hour for children, not within 3 hours. And so this also comes back to, if we're going to track metrics, then it really would be useful to agree on what those metrics should be so that data could be compared across sites. Lastly, this is the group from Boston. Raina Paul and her group looked at adherence to a sepsis bundle. And this is a more sophisticated SPC chart, but showing on the y-axis the percent adherence to the sepsis bundle over time, and with the x-axis showing time. And they've also shown an overlay here of what their various quality interventions were and how that related to changes in percent adherence. So different ways to look at this types of data in patients with sepsis. Now, all of these publications pertain to patients presenting to the emergency department. Lastly, and this is from the Clinical Excellence Commission in New South Wales in Australia, this isn't an SPC chart, but this is rather just simple tracking of median time to antibiotics, but certainly nicely shows that over time, they've really had a real improvement in delivering antibiotics to their patients in a timely fashion. So to summarize, wouldn't it be nice if we could all agree across centers on what data collection goals would be? And how could harmonized multi-center data potentially be used? Well, this is an example from the Canadian Neonatal Network, where they're actually showing very nicely here what the risk-adjusted odds ratio for mortality is among all neonates by sites. So they've actually anonymized the sites here. Sites get their own data, but they can actually look at how they're performing relative to other sites, and that's something that we might aspire to. So future directions. We know that sepsis quality work is being done at various Canadian pediatric sites. There's a lot of great work going on in Canada right now. We think that we have a critical mass and some basic experience such that we can try to move towards collaborative multi-center work. Obviously, the goal would be to create a sum that is greater than its parts and to learn more through collaboration. But funding and support is really required to take on a project of that nature. And we do know that there are actually multiple project partners who are out there and willing to financially support such work because we've had discussions with such groups over the past year. And with that, I'm going to turn over the podium to my colleague Jane, who's going to talk a little bit about their experience at Sick Kids with their quality initiative.
Yeah, all right. Well, why don't we take a couple of questions, Dr. Parker? Well, maybe Jane can figure out what her issues are. I'm not sure what's happened. We heard her earlier when we signed in, so I'm not sure what happened. But all right. Well, the questions that came in were just related to the SQUEEZE study. People just looking for more information on where they can, how they can be in touch with the folks running that study, so they can be alerted to findings as they're made available. Who would they be in touch with?
Sure. I'm the principal investigator of that study, so I'm more than happy for people to contact me directly, and I'm happy to give them some information. We're hoping the protocol manuscript for that paper is actually hopefully going to be coming out in the peer-reviewed literature soon, so there should be a journal article talking about the study, and we expect to be presenting some results of the pilot study later this year. In terms of the other place that people can look for information, and it's actually, there's a link in my slides, and I understand that those will be actually sent out after the presentation to test out a study to see if it works, if it's safe, and to make any changes to the study.
But if there are any questions from the audience, please do. Dr. Parker I'm sure will be more than happy to try and answer any questions you do have. And we do have about 15 minutes left, so if we do hear from Jane, then we can try and bring her in at that point. But if you do have any questions, please don't hesitate to type those in.
Well, I mean, if I can just add, Doug, because we do have a little bit of time left, I'd be happy for any questions or even input from the audience in terms of what are your thoughts around the challenges with.
Okay.
Yeah, I'm not sure either, because we did hear you earlier, but we can hear you now. So why don't we just move into that portion of the presentation? You've got the slide is up on the screen there, and why don't you take it away?
Great. Okay, sorry about that, everyone, and thanks for having me speak today, Doug. Thank you, Melissa, too, for your talk. My presentation is really going to just complement Melissa's and give the group an example of how we at Sick Kids in the Emerge use the QP data to improve our practice. The work I've done is with Dr. Schoenfeld, and initially we started working on paper, and what came of that is we started to think is with the data that let's talk about our sepsis project then. Okay, Doug, can you go, or Melissa, can you go to the next slide? Thank you. So we found that we were using a paper protocol at triage to identify septic patients, and we wanted to improve practice, but we also wanted to have some way to have data collection. So therefore, we thought the best way for that is to use our electronic system in the Emerge and build a tool into that electronic system. And with that tool, we are able to screen our patients and improve clinical outcomes indirectly, but also with our tool, we have been able to collect QP data to use. So if you can go to the next screen, the next slide. I'm a bit rushing because of time here. So that being said, we built a tool into our EDIS system that the nursing staff at triage would use to screen all patients for sepsis upon arrival. Okay, and the tool is twofold. It screens patients and it also triggers a sepsis alert. So at this stage, we are really just beginning to collect data related to our screening. Okay, so that data is electronically generated, and we are hoping over the next few months to have at least 80% of our patients that arrive in the Emerge all screened for sepsis. All right, and to this date, we have been quite successful in screening over close to 100% of our patients are all being screened, and we're showing that in our data. So that goes to the point that Melissa was saying, where do you start and in this big haystack of sepsis, and how can you use this data to improve practice? And we chose this as our starting point at Sick Kids as the way to collect data and improve the practice for our patients. So formally speaking, we are screening all of our patients. Over 98% or 99% of our patients are being screened. And informally, we haven't started to collect data, but we are finding that care is more timely on this patient population now related to this sepsis alert being flagged. So that being said, we are trying to decide what will be our next point, as Melissa said, of where we will collect data. How will we flag that, and how will that data be collected? Will it be the time the fluid bolus is given or the antibiotics are given? That has to be decided. But that's what we are moving to in the future. Now, I would like to say that the QP data collection has been very important, as well as the support from our hospital managers, and using this as one of the metrics on our scorecards, screening all patients for sepsis has helped with compliance and helped to move the projects forward, I think is important to note. So you can see on this slide, this is an example of the sepsis alert on a patient and what it looks like when you are using the electronic tracking system in the eMERGE. Okay, so I guess complementing Melissa's presentation, we sort of in this sepsis community all agree on what is the next type of data that we want. Do we want the time to start antibiotics, the time to start fluid boluses? But this will be very important moving forward so that we can all work together and have better outcomes for our patients. And that's sort of my angle on it, what is best for the pediatric patient in the background. Okay, Doug, I'm good.
Thank you, Jane, and glad we could get that. That was really great to see how this is playing out, at least at Sick Kids as an example. So that was great to hear. Well, we did have a question come in from Connie. Maybe Jane, maybe you can answer this for us, and Dr. Parker, if you are able to get back on the audio, certainly would love to hear your thoughts on this. But she's just asking, and Dr. Parker mentioned this, that there's lots of stuff happening, and one of the opportunities going forward is how to build consensus around some of these indicators and standardizing the data collection. But Connie's asking, what data do you think we should be collecting? And she's also interested in how to evaluate education and provider capacity building and team training, etc. So, just from your perspective, Jane, maybe we could start with you. Like, what data do you think people should be collecting, to look at this from a national perspective?
Well, definitely the identification time. So when we create the alert, and then the decision to begin a protocol type care, how long that time is, I believe is important. And then timeliness to fluid bolus and medication administration. So those are some of the time stamps. Now, as far as measuring or showing education for staff and outcomes, a lot of times implementing these protocols and is a process issue. So you're trying to put the processes in place so that staff can implement these protocols. And there's communication processes as well as team issues, electronic charting issues, all of these things. And then to see if it is working really, it's almost like feedback from staff, and then the timeliness to care using the QP data. But seeing if the staff feedback, it has to be survey or group discussions, charge nurse discussions, that kind of thing.
All right, thank you. No? Okay, we're trying to get Dr. Parker to dial in by telephone, so maybe since her microphone seems to be having... But the next question that came in is from Kat, and she's asking, who do you think are the necessary stakeholders in creating a sepsis protocol? So who within the organization needs to be involved in this?
Well, I can answer it. I'm back. Hopefully you can hear me clearly now.
Oh, yes, we can. All right. So the question, I'm not sure if you heard the question, Dr. Parker, and we'll hear from Jane first, and then maybe we can get your thoughts. But Kat's just asking, who do you think are the necessary stakeholders in creating a sepsis protocol? So Jane, what are your thoughts on that?
Well, I think for pediatrics, we need the emergency, well, we need a representative from each area, emergency, ICU, as well as the wards, working together on the protocol, because it's a multidisciplinary protocol too. But I think the management also has to appreciate the value in it and then use it as reportable data, and that really helps to spearhead the project. If it's one of the indicators that the hospital is wanting to have improved, then it will improve itself. I don't know if you want to add to that, Melissa.
I think just to expand on what you've said is that the short answer is everybody, because you need the clinicians. Sorry, you're getting an echo from my computer now. You need the clinicians, the researchers, the administrators, and arguably even the patients to actually participate in discussions around what those metrics should be.
All right. Well, thank you. That's a great answer. Any other, just for the audience, any other questions before we've got a few minutes left? We did have one just come in from Matt. He says, as the Sick Kids program has been implemented, has there been a perceived uptick in false positives? He's thinking of kids with fever and low-grade irritability who are tachycardic at triage, perhaps. So has there been an uptick in false positives since you started the program, Jane?
Okay, so unofficially, we did not collect that data, but we have been keeping an eye on that since we initiated this sepsis alert. And no, the answer is no, there have not been a lot of false positives. The alert, basically, people are saying they were worried about that, certainly. That was staff feedback. But the staff physicians, as well as the fellows and nursing staff, are finding that it's because it's there's a protocol now, they're able to quickly assess and make the decision whether we activate the sepsis pathway or not on these patients. So in fact, they are finding it more helpful with that population.
And Melissa, any thoughts on that around false positive after implementing this kind of a program?
Yeah, that's a great question, and it is certainly one that needs to be considered, because the issue of false positives is potentially very problematic. Many people are familiar with what's referred to as alarm fatigue, particularly in the ICU setting. If you're constantly getting alerts or you're constantly getting alarms, then the risk is that people will become less vigilant. And obviously stakeholder buy-in is really important for these alerts to be working. So I think the key aspect of what Jane just mentioned is that the alert in their protocol is the trigger for someone to go and look at the kid and then make the clinical decision as to whether the protocol should be activated, because if that happens automatically without some clinical judgment, then we don't want to be in a situation where people are putting intraosseous needles into febrile screaming children because their heart rate's 200 because they're angry, but they just have a viral illness. So there are very real issues around what can be considered sensitivity and specificity. I mean, we want to catch all the cases, but we want to do that with a minimum of noise. And so there really is no gold standard protocol right now, but many different groups have come up with protocols. So there's the CAPHC protocol that was recently released in terms of the CAPHC Sepsis tool. There's the Sepsis 6 from the UK. So many different groups are trying to, I think, identify that holy grail, and it really is a balance between minimizing false positives and not missing cases.
Right.
And can I just add something? Sure. I think that the false positive things too, look at them differently. There always is going to be the patient. Out of the 10, there might be, or out of the 21, that the alert is active. The pathway is not activated on. But that's what it's for. It's to make sure we catch the ones that need it, not the, and we're always going to have someone that doesn't need it. But really, it's sepsis, so it's very important for the outcomes of the patient to have this pathway and have those false positives. That's okay.
Thank you. And we have one more comment that's come in from Connie, and we are just about out of time. Fortunately, we did get some good discussion going despite our audio difficulties, so apologies for that. But we'll take this one more comment, and then we'll maybe pass it over to our presenters just to sort of leave us with some closing comments after we finish with this this comment here. And this one's actually a good one to end with. Connie's saying that many folks speaking at the Sepsis Congress talked about the need for government or public and government/public and health system collaboration to mandate sepsis programs and data reporting. And she's thinking of the example of New York State. She says, what could that look like in Canada? And how can we, I guess, as the community across Canada, support this kind of collaboration between the government/public and healthcare system? Any thoughts, Melissa? We'll start with you.
Yeah, I'm happy to take a stab at that. I think there's excellent examples from other countries right now where there has been active lobbying and engagement of government, particularly in the UK. With the UK Sepsis Trust to try and raise awareness and through that also get funding to support these types of initiatives. Here in Canada, I think that there has been work going on behind the scenes that not everybody is aware of. Certainly, there have been folks this year, including myself, from a number of hospitals in Canada that did put our heads together to put together a proposal for how we could do some multi-center data collection and try to work towards the types of goals that we've discussed today. And we did actually have approached and had buy-in from a number of partners, including local, provincial, national, and even international, that were willing to support that work. So I think, and very different partners as well, ranging from hospitals to government health agencies. And so I think there is broad interest in this topic and a willingness to partner and provide in-kind or direct funding. But obviously we need a critical mass of resources to move it forward.
Jane, any thoughts on this about government and health system collaboration to mandate, sepsis programs, data reporting, et cetera, and how Canada could implement something like this?
Well, I think Melissa described what I would say. Really, it needs to be part of the accreditation process in Canada if that's what we're going to move forward, because the hospital, I think, is driven mostly by what is accredited and what the government is expecting, because the money does not go everywhere, and what is priority is what the government is asking for. So that would be my take.
Suggestion to build it into the accreditation process. That would certainly give it some impact, for sure.
I think so, yeah.
So I think with that we are out of time, and maybe we'll start with you, Jane, since we've got your voice here. Anything you want to leave the audience with? Any resources? Any final thoughts? Any key messages that you'd like to leave the audience with?
I think two key messages. It's a multidisciplinary project, so you need to have representation from your teams, and it's a big project, but tease it out, start with something small, and move forward in your hospital one step at a time, and keep that in mind. The journey is will be long, but each step you'll have some gains for your patient population. That's
Thank you, and thank you very much. And Dr. Parker, any thoughts from you before we wrap up?
I would just really support what Jane said in terms of it being a multidisciplinary issue, and really just if anyone's concerned about sepsis, whether it's a nurse, a medical student, respiratory therapist, in a patient, they should speak up and not be afraid to share their concerns, because that's really how we get to early recognition and early treatment.
Thank you very much, and I think that with that we will wrap up. So again, huge thank you to both Dr. Parker and Jane for a great presentation, and thanks to the audience. And again, once again, our apologies for the technical difficulties. I can assure you that it's rare. We do these webinars every Wednesday at 11 a.m. Eastern Time, and I think this is the first time we've had that experience. So, so thanks again, everyone, for coming and participating and engaging in this in the presentation with your comments and questions. It's always great when you can do that on the live presentation, but when you can't, join us live. As I mentioned earlier, we do record these sessions and make them available after the fact on the CAN. Usually takes us a couple of days to get those up. Our next webinar will be next week, September 21st, and we'll be welcoming our colleagues from the CIHR network, which is the Children and Youth in Challenging Contexts network, to talk about supporting young refugees through school-based solutions. And this webinar will look at school-based initiatives to support mental health and successful resettlement of young refugees and newcomers to Canada. And then on September 28th, we'll be having a presentation on implementing the NFIT standards, preparing for the impact on clinical practice. We're going to learn about the new NFIT standards for enteral feeding systems that will be implemented starting in 2016 and the potential impacts across Canadian institutions. We'll be hearing from Tom Hancock, who's the Executive Director at the Global Enteral Device Supplier Association, who's going to be sharing some background on the issues related to tubing misconnections that drove this change from a patient safety perspective, and then the drive to develop a new standard to prevent accidental misconnections. And then we'll be hearing from Dr. Gina Rempel and Mary Ellen Lee from the Children's Hospital at the Health Sciences Center in Winnipeg to discuss the impact of these new standards on clinical practice, and in particular how this will impact some of the off-label practices that use enteral feeding tubes, for example drainage and suction, that will be impacted by the NFIT conversion. So as always, some great stuff coming up in the next few weeks. Thanks again for joining us today and for your comments and questions, and we hope to see you back here next week. Bye, everyone.